I think a lot of the issues started with, honestly, with social media is people made up things like it was cardioprotective or neuroprotective and stuff, which again, it is to a degree, but it's not really, as we see with the birth control. Once the estrogen level is above the normal range, all of a sudden it starts to cause harm, right?
All right, we're rolling here. We got the crew together. So Mr. Holcombs, Ella, thanks for joining, and Kurt Havens, great to have you.
Thanks.
We've done a lot of stuff before, but just glad to have everybody on. Just for those out there, we're kind of talking some overarching health concepts, discussion topics, hoping to clear some air, add some context to things. You know, Ella and Kurt both being heavily formally educated in the areas of research, things of that nature. They can kind of shine a light maybe on some questions I know I get from people, and I've had some people send in questions for this episode, which is definitely appreciated. And I'm sure Justin, with the hundreds of people he's worked with, will have plenty of anecdotes too. But with that, welcome to the show, guys.
Thanks.
Thank you so much.
Everybody.
Justin, did you have anywhere you want to start with what we have going on? What's everyone what do we got going on out there?
Yeah, I just my daughter was born like 48 hours ago.
Wow.
So that was a cool experience. We had a home birth, so that was also a new experience for me. So kind of seeing things done non-traditionally was very cool, kind of eye-opening, the natural things you can do to induce labor and have a safe home delivery. So baby's healthy, everything looks good. We're just kind of getting into routine and trying to figure out how to sleep. You know, the first 3 weeks are quite hard. I already have a 5-year-old, so I've done this once, but it doesn't get easier the second round. So
No.
we're just working through it right now.
Yeah,
Thank you.
Yeah, welcome to the Daughter Club, man. Kurt, do you have any girls or just
I have one boy and one girl.
one boy, one girl? Yeah, I have 2 girls, and it's awesome. Get ready, man. She's gonna have your wrapped around her finger. So.
I'll be in ink playing and doing all those things, I'm sure, and I'll gladly do it. I've had my fun with my son. He's rough and tough, so it'll be nice to have the opposite side of that. So looking forward to it.
Yeah, and you're super regimented with like sleep and training and supplements and all that. So I know this is probably out of the ordinary for you now. Kind of nice curveball, but a welcome curveball for everything, right?
Yeah, it is quite different. I actually made it to the gym today. Snuck away for about an hour, but yeah, it's been different trying to get my food and everything in routine. But just like anything, it's just going to take some reps, and I'm sure I'll find my groove.
I'm curious too. Was there anything that stuck out to you, like when you mentioned like different natural things with birth and doing it at home? Was there anything specific that caught your eye with all the things you're studying and looking into at all times? Like, was there anything that kind of piqued your interest when you're experiencing that?
Yeah, I think like even adjustments from chiropractors are really interesting. So, as a mother is getting ready to give birth, there's a lot of shifts to the hips. So to get that baby to be head down, I have a local chiropractor here. He specializes in prenatal stuff. So they set her up really nice. You can use acupuncture and other things to kind of induce labor. And then the midwives were doing all types of potions and things to stop bleeding, hemorrhaging. So it was really cool to see a lot of those natural remedies, as previous, Pitocin, things like that are usually given in those settings. And there's nothing wrong with that. We wanted to look at a alternative way of doing things. My interest in non-traditional medicine, just kind of, my wife wanted to do it, and I was like, well, yeah, why not? And it was a lot more personalized. I think of that almost like concierge medicine. We have somebody come in and consult with us for months at a time. So feeling very safe is like you go see your OBGYN a few times, and most of the time you see the nurse practitioner or whoever's going to deliver the baby, and it's like show day, and it's a lot of strangers. So it was really cool to have more of an intimate setting at home and familiar faces. And I think my wife really enjoyed it. I'm such an advocate of my health and what I want to do with it. It was a no-brainer. I was like, well, you want to, not have an epidural and no medicine. If you think you can do that, great. So she did it, and it was awesome. And I commend her, because I'm definitely not that strong.
Did your first child was born in a hospital?
He was a cesarean as well.
Okay.
So, we actually have a really high mortality rate in my state. It's not, it's not astronomical, but it's high as far as like the United States. So that was something we considered. Cesarean section in the US is quite high in comparison to other countries. So um, we just wanted to avoid that as much as possible and try to do things as natural. I know not everybody has that option, but my wife is very active. So she was kind of a prime candidate to do a home birth, and we were blessed that everything worked out fine.
Cool.
Yeah, I think my second daughter, when she was born, like those tells you can pick up, like I don't know where I picked this up, but like just different tells people have when they're like lying or nervous, right? And one of them's the hand, if the hand's trembling a little bit. So the nurse was rushing to set everything up, and I was like, is the doctor on the way? She's like, oh yeah, doctor's on the way. So she kept repeating that like 3-4 times. So at the last second, I looked down because I forget exactly where she was, but it was close. And I saw the hand trembling, and I didn't tell my wife because I was like, oh, she's completely lying through her teeth. Like the doctor, she is freaked out. And I wish I didn't know that, like to look there, but like my brain went to look, like something seems off. I don't think she's telling the truth. She had this little like it was even more subtle than what I'm showing, right? It was very, very subtle, but I could see out of the corner of my eyes, like, oh man, she's totally freaked out. I'm like, luckily, right at the last minute, I didn't have to do anything out of my comfort zone, so we were good to go. But things with your wife along that time. Were there any other things that you see like with clients that you work with?
I think it's kind of like the basic things that most people skip out on is I think a lot of women become pregnant, become immobile, or and aren't able to or do not want to continue exercising and eating well. And we look at like edema, eclampsia, all of those issues. So getting adequate nutrition, movements, lots of red light or sunlight, those are things that we were just implementing in, and obviously a good prenatal. But I think most people kind of miss that bar on a day-to-day basis is like, we're not eating well and we're not moving. So towards the end, even just walking for 15 minutes is quite hard when you're up 45 pounds. But just doing those things, lots of mobility drills. I know some people probably think it's woo, but lots of affirmation. She was spending quite some time really, just trying to be calm through that process. And she handled it. I was really freaked out. I think her mom was also really freaked out. But when she was done, she was like, oh, I actually kind of enjoyed that. And I was like, that is pretty crazy to say that. But okay, I'm glad you like
well,
that.
Transitioning a little bit, kind of overall men's health. Ella, just curious, just kind of for open discussion, is there any hot topics out there that you're seeing as far as men's health that you want to open up to the group?
I would say for specifically like on the topic of like endocrinology, I would say a lot of like the testosterone booster thing has become really big in the health, like the general health space, where literally every other like, I guess, general health video is now like a testosterone boosting supplement or something like that. And then another one, and this would go along with Justin's like niche, would be like improving gut health. The word gut health is thrown around like a little tennis ball all the time. So it's like I feel like those two things really would kind of vibe with both of your guys' like specialties. Yeah. So
Is there anything you're seeing out there, Kurt, with like testosterone boosters, or any opinion on kind of some of the marketing you see or the products?
Yeah, I mean, most of it's just garbage, right? I mean, if you're getting adequate vitamins and minerals and your diet's good and you're getting recovery, I mean, they're not going to do anything. Even if they produced whatever 20% increase, really, what is that doing to the total number? It's not making an adequate change. I was sponsored by a supplement company for a period of time, and one of their best-selling products is a testosterone supplement. And they asked me to speak on some of these things, and I was like, I'm not speaking to a testosterone booster. Yeah, I mean, I get it, right? The HRT market is huge. There's a lot of money to be made there, and people are going to try to tap into it any way they can. And there's lots of men that are afraid to go down that road, even if they need to. And there's a lot of doctors that are afraid to address it when patients come to them, right? Even though, the word on the street is that testosterone should be removed off the controlled substance list this spring. So it should be an open label drug. It'll be prescription still, but it'll kind of alleviate some of the stress on the prescriber with dosing and right. Because I mean, there's very strict guidelines as to what we can write and like the frequency and what amount you're allowed to give. Those should hopefully be removed to some degree. It doesn't mean doctors are going to write for grams a test, but
Right.
it should at least allow doctors to be a little more relaxed about how they're going about it. Because you see some strange practices with TRT now as it grows, where just the dosing is odd. Doctors are very nervous about using an adequate amount, and with the making up these nanogram per deciliter limits on blood work that they need to keep you under, which there's no law there. Not to go off on a tangent away from the test booster. The test booster doesn't do anything. The HRT market is growing faster, I think, than we can keep up with as a nation. And I think it makes sense that it should be more readily discussed. I think general practitioners or whoever wants to get into that should probably have more education on that subject, right? In medical school, initially you're given these blue books on all the subjects. The endocrinology one is like, you can read it in 2 weeks and pass the test. It's a joke. And it really just, brushes over some of these things so that they're not even taught how these things work, how it's prescribed and all these things. And then of course they're allowed to write for it, but then they're nervous to do it correctly.
Right. Yeah, I've seen either from super low, super high to high. And when I say super high, I should say relative to replacement, because they're doing a higher amount, but it's like a once a month, type shot. Like I'm talking like a shot of.
Well, that's the guideline. I just saw I was just sent the new guidelines for testosterone supplement, and it's, I don't know where it is now, but basically said it was one shot every other week or a larger dose every third week. It was like, who doses it like that? But those are the guidelines.
Interesting.
The doctors are just following what they're told. If they don't understand how the ester works, that's just what they're going to write for.
Sure.
And also you have patient compliance and you have fear. So most men don't like needles. So if you tell them, split the dose up and take it twice a week, they're like, wait, I have to inject this twice a week?
Right.
And so a lot of them don't even want to do that, right? So you just go to your doctor and he gives you a shot and you come back in 2 weeks and you get your shot. You don't necessarily feel great and your levels are all over the place. But that just seems to be.
Do you feel like the guidelines are changing a little bit as, I don't know, I'm going to make a guesstimate, but I was doing some searching, like 15 maybe years or so, maybe 20, like it seems like there's more studies showing like some positive benefits and or debunking some of the other concerns out there relative to certain cancers or certain cardiovascular events, things like that, where it was maybe some of those old studies, they didn't scrub the participant list before. They didn't really vet to see, do they have previous conditions? Like I know that was something that was a hot topic. Like what are you seeing out there as far as the research goes and any things that are kind of.
It's changed a ton. In that time frame, it's changed a ton. So we actually define modern men's endocrinology as the pre-Bazin era and the post-Bazin era. So there was a doctor who is in private practice now, last name Bazin.
Okay.
He's in Massachusetts. He did the original testosterone dose. Everyone's seen these dose response, the graded dose response testosterone ones. Previous to his work in the medical community, it was misunderstood that testosterone even had anything to do with muscle growth. It was debated if it had any effect at all. And a lot of doctors would just debate that it stopped muscle breakdown. So then you would net growth from them. So he was the beginning of kind of the way we changed to look at these things, like how it should be prescribed. And that's also where the super physiological thing, I think a lot of the problems are things misdefined. So super physiological doesn't necessarily, when you're talking about testosterone therapy, it doesn't necessarily mean it's just simply greater than you produce, right? Because a lot of specifically urologists or general practitioners are very nervous around testosterone, will try to come up with the dose that mimics your natural production. Like, well, that's what TRT is. That's not technically what TRT is. Under 300 milligrams a week for the average human is still going to be considered a physiological dose because it's not going to yield any muscle growth that you wouldn't without it. It has nothing to do with mimicking the 10 milligrams you produce naturally. So it's just defined incorrectly. And that's why the dose for TRT is generally capped at 250 unless there's a disease related, right? For cancers, you can write up to 1,000 milligrams. and all sorts of stuff. But yeah, but like you were saying before, there's tons of research now looking at all these things and these health benefits. I'm in the middle of one where I'm establishing the pharmacokinetics of testosterone cypionate, which was never done before. Drug came out in 1951, and no one ever bothered to look at it. No one ever bothered. They just assumed that it was the same as enanthate, which it's not. Unfortunately, I'm not going to spoil the research. I can send you guys the initial stuff that we wrote. So I'm doing it with a doctor out of Florida, and we're doing a controlled study between testosterone, enanthate, and cypionate, and looking at the blood markers and seeing actually what it does, because they're totally different drugs.
That'd be really interesting.
I mean, testosterone is testosterone. Add an ester, it changes the kinetics of the drug. So there's tons of funding. There's tons of research that goes into this stuff. No, I think it's a great time to be doing what we're all doing. I just think that there's just a lot of stuff that's left, but there's a lot of education left behind, right? And people stuck in old ways. As far as health risks, Dr. Dean, who I do a lot of videos with, just is writing a book now, and part of it is on the risk of steroid use, things like that. And it's actually, if you look at the actual deaths associated with this stuff, if you removed pre-existing conditions, it's almost none. So I think over time these things will change. It just takes time for the education, and medical school's behind.
Sure.
I have a question for you, Kurt, because you're in the know with so much of the testosterone. Do you have any insight on the oral testosterone undecanoate? I see a lot of people talking about it's. I see a particular HRT clinic promoting it right now, and curious your thoughts on that, or if you have seen anything on it.
Yeah, I mean, it took a long time for the FDA to approve it. There were financial problems, and the pharmaceutical companies kept pulling out of the projects. It's not as effective, obviously, as injectable. I think it's a valid option for a guy who is needle phobic or someone who wants to try, right? It's probably a better option than a gel or a cream from like a user standpoint. You don't have to worry about contamination, getting it on your significant other or on your children and applying it 3 times a day. It's just not going to, right? So that ester basically is so long that it'll go through the lymphatic system instead of the liver. But you're looking at such a minuscule amount of testosterone that's actually getting in serum. But again, it's better than nothing. If someone is seriously hypergonadal, it's going to make an improvement. It's obviously injecting testosterone would be a much more efficient way to raise that.
Yeah, and I don't know if this is obviously none of us are practitioners writing prescriptions, so if we don't know this, I heard it anecdotally from a pharmacist. But do you happen to have you heard the conversion, if you will, like this many milligrams injectable versus this many milligrams oral? Because I heard again, this is from a pharmacist, but it was like around, I want to say, a 20%, but I don't know if that's again way off or not. I can personally read it.
No, I can find the information. A pharmacist would actually know first, because they're the ones who have to do the conversions for the dosing.
Right.
But I can spend some time, so you can put in the notes of the podcast if you want. I give you
sure. Yeah. I was just curious that was one of them. They do. They were kind of one of the early pharmacies, if you will, in that space that started with some of the oral deliveries that what you're talking about that go through the lymphatic system, and that's what they were recommending, kind of around that range, and then obviously follow-up labs to test it and such. But
I have another question around that, and if we're just speculating, it's fine. But I have a personal friend who's been using it and had been on injectable replacement and is swapped, and obviously while he was using injectable testosterone, his LH and FSH were suppressed. But when using this oral undecanoate, he claims, I haven't seen any lab work, that gonadotropins are restimulated, and he's having, normal levels of luteinizing hormone and follicle stimulating hormone. Do you think that is maybe just antidote and a one-off, or is there?
No, if it's not. So you see that with testosterone propionate sometimes too, depending if the dose is low enough. That's why, like with drug tested athletes, a lot of times they'll use propionate because it'll run parallel to the natural production. If you take a dose that's low enough that it's not going to fully cause suppression, you'll see that. So because it's not actually fully suppressing that feedback loop. So that's why his LH is still elevated, which can be a positive thing, right? If you still want to have children, but it could also be a negative thing because you can get different side effects if you have both going on at the same time.
Yeah.
So that's most likely the dose is too low. It'd be like if you injected 50 milligrams of testosterone cypionate, for instance, you'd probably still have some LH and FSH, but what is the 50 milligrams doing? Probably nothing.
Sure.
And if you test it in the blood, you can see the carbon difference, the carbon 12 versus 13. That's how it's detected in a drug test. Now, in the Olympics, you'll see them running parallel. But from like just a pure, like if you were doing a test, the initial test generally just, that's one of the things I look at. So look at LH, I'll look at FSH, right? To see, because if there's 0 or negative, like, someone's on something. If that gets flagged, then they'll go to the next level. But you can pass generally like 200, 300 milligrams of test propionate will still not cause full suppression in a lot of guys. So you'll still see that. And yet they're clearly super physiological. They can't, because they can't judge based on total test in your blood, unless it's over, it'd have to be very, very high. But that's all he's seeing. He's just not fully depressed from it.
Sure. Yeah, I was really interested. The last piece of anecdote from him is that his estradiol was quite lower on the oral versus the injectable. I thought that was interesting because if you have endogenous production and supplementing exogenous, that you probably would have more estradiol. And again, that may be a one-off.
There's so many factors, right? Body fat, how much of that aromatase enzyme you have, what the level of total test is, right? So on average, it's going to aromatase like 5%. So if his total test is only a 600 or 700, how much are you really aromatizing? Unless someone's very heavy or has something going on with that aromatase enzyme, you're probably not going to produce a ton of estradiol, right? So you generally see it in guys when they first inject things and their body fat's still high, that estrogen will shoot up, right, until they get their body fat under control. So that's it's not necessarily anecdotal. It's just that's probably a function of the level not being super high.
I also had a question. Well, actually, I had two questions. One was, I know this is all on the topics of men's health, but I personally have PCOS and my testosterone is really high all the time. I'm sure, like, I'd be curious to know, like, if there's, with the new like the amendments to testosterone, like just being used in pharmacology and like for medicine, I would be curious to know if there's going to be any sort of like revisions to hormone replacement for women who have like issues like PCOS.
To my understanding, the only controlled substance is injectable testosterone. So your bioidentical estradiol or estriols, progesterone, those are non-controlled substances. So there's a lot more leniency with those versus the testosterone is, I don't know exactly. I'm not a lawyer, but it's up there as far as is it a Schedule 3 drug? Yeah. So, I mean, it's not taken lightly as a.
No, it's technically punishable, same as cocaine or heroin.
Yeah.
Yeah.
No judge or cop would punish it that way, but that's how it's written.
Oh, geez.
Yeah. Women's health always seem to be easier to navigate than men's. It's more complicated. I think it's harder from a practitioner standpoint, but from a legal standpoint, right? You can give a 14-year-old girl can get put on estrogen for birth control, but a guy, a 50-year-old man that wants testosterone, a lot of times has to find the right doctor who will even look at it.
The only issue that I've run into is every time that my doctors put me on, they put me on like birth control a few times, and I got like extremely depressed. So like I was like wondering, because there's a few conditions that are in women's health that, even though they would be fairly easy to treat, they just don't get treated the right way.
Absolutely.
Was the birth control, with the progesterone or just straight estrogen?
It was progesterone.
It's most likely from the progesterone part that's causing the depression. There's a lot of new research to the show that, and it does cross over back to men's health when we talk about estrogen, but there's serious stuff that goes on in your brain when estrogen and progesterone get out of range and they get high. So it actually causes the hypothalamus to start to shrink, and then the pituitary gland will shrink. The thyroid function shifts and becomes much worse. So this is relevant with men bodybuilders for nandrolone. Nandrolone is an atrocious drug for your brain because it's hitting all those same things. So you want to be careful. They did massive studies with women long-term that were on birth control. Now, they didn't rule out, like we talked about before, some pre-existing stuff, because that's kind of hard when you're looking at 60,000 people. And they also didn't rule out drinking or smoking, which can affect the brain as well. But you're looking at 61,000 women on these drugs, you can come up with a conclusion fairly confidently, in a large sample like that. So and they did MRIs on their brains, and they could actually see the size of these parts change, and which affected the limbic system and their memory.
Wow.
And all sorts of things. And you start to see that even during pregnancy, as a woman's hormones start to peak during pregnancy, her brain will actually start to shift. And then it goes back to right after birth, and it goes back to normal. But the problem is, long term, if someone's on these birth control drugs from the time they're 14 until they're 30, what is it actually doing to them?
That actually, I'm so sorry. That actually made me I know this is probably an obvious answer, but I was just curious because I dabbled in this area.
Mm-hmm.
If these drugs can cause the shrinking of the hypothalamus, would this affect the melanocortin circuits as well?
Yeah, it would.
That's interesting.
For the audience member.
Oh, I'm sorry.
What does that mean? No.
The melanocortin circuits affect your satiety. So melanocortin is this little circuit in your hypothalamus that's constructed of a bunch of, a group of neurons, particularly POMC. I believe it's a goody protein peptide 4 or something like that. I'm sorry. I'm like, I don't have it all like memorized, but then there's also melanocortin 4 expressing neurons, and they all work together to promote either a feeling of fullness, feelings of hunger, and then they also help to regulate metabolism. So when you brought up like hypothalamus and then your thyroid, I immediately thought like, oh, melanocortin circuits, maybe something could be going on there, which would be kind of interesting because we've got some drugs that do address melanocortin circuit issues.
And you're looking at it from like an appetite point of view.
Mm-hmm.
So estrogen in and of itself too will modulate appetite both when it's high or when it's low. That's why again, not to go back to bodybuilders, but when guys use drugs like equipoise, that's why some guys get extreme appetite stuff from equipoise, because it aromatizes to something called estrone. It doesn't aromatize to estradiol, so it suppresses estradiol, which can make, in a lot of cases, just people have a ravenous appetite. So women's birth control is not necessarily the best option unless it's needed. I don't think it should just be prophylactically prescribed to teenage girls to, solve that problem.
Yeah, it's in my personal opinion, I have not had a good experience with PCOS. And it's like you hear it all the time especially with like endometriosis, we're finding new things out all the time.
I think it's just an easy way to kind of address something, put a Band-Aid on it. I think of PCOS almost like a spectrum. There's so many different interplays when we look at that condition. Androgens, inflammation, insulin resistance. There's a lot of different things that could play a role in PCOS. And I think a lot of times practitioners are limited on time, and they're not going to be able to really look at a root cause, or they may not have the testing modalities available to look at more sophisticated things, some of the upstream metabolites that could be causing issues downstream. So I think that's where integrative medicine really shines. I take a lot of focus into women's health and work with a lot of women with PCOS or endometriosis. I don't think that birth control I don't think any drug is good nor bad. There is a purpose for drugs. If we're looking at hyperplasia of the endometrium, you may need something like that if you have some type of cancer or abnormal growth to suppress that. But I think a lot of times improving lifestyle and doing the right types of testing, supplementation, and then alternative therapies seem to be quite helpful for PCOS. I think you just really need to know what you're looking for. Having a practitioner who's open-minded.
Yeah, I was reading up a little bit on that. And there was a few interesting things that I feel like are very niche and underappreciated. That like specifically with like the whole PCOS thing, there are a few things that I feel like are more specific tells of PCOS that aren't like readily spread out, and a lot of people get misdiagnosed because a doctor will see a cyst and say, oh, it's PCOS, but little do they know like a cyst can be normal, But when you see a bunch of cysts that are all like little bubbles all over the place, then that's more telling of like an actual like PCOS condition. So it's there's just so much we don't know. But I guess like going back to like the whole men's health thing, the whole concept of like estrogen, I feel like that's another area where a lot of people start to like in the supplement industry, they like fear monger it, especially like, oh yeah, oatmeal or this food, that food is going to increase your estrogen and kill you or something like that.
I think I got, I think you have a clip on that, if I remember correctly, don't you? You might have a few.
I pulled from my folder in the back of my brain.
We've even changed the guidelines with women's estrogen-dependent cancer and soy. So soy doesn't really seem to have any negative effect on estrogen either in women, which is funny because people in Asia have been using soy for thousands and thousands of years without issues. Yeah, the food stuff with it is, I mean, really where I would put my professional stance on estrogen is it needs to just be in range. I'm not sure why it needs to be low. I'm not sure why it wants to be high, right? If it's too high, it can become a carcinogen the way it's metabolized, and there's no physical benefit. So I think a lot of the issues started with, honestly, with social media is people made up things like it was cardioprotective or neuroprotective and stuff, which again, it is to a degree, but it's not really, as we see with the birth control. Once the estrogen level is above the normal range, all of a sudden it starts to cause harm, right? It's not necessarily kidney protective. And estrogen is, it's going to act differently in men and women, where it might have one function in a female's body, it's going to have a totally different function in a man's body. So you can't just sum it up by saying estrogen is this, right? It's our bodies are different in the way they deal with things, totally different as well. Okay. With cardio stuff, which is funny, when people come to the ER with a heart attack and you run labs, if you run hormones, they always have high estrogen and low testosterone, 99% of the time. So the whole estrogen is cardioprotective in men is a crock of shit. It's actually testosterone is cardioprotective in men.
Where do you,
oh, sorry.
Go ahead.
I just want to quickly say, I feel like every area of science can kind of come, like, even though like a bunch of different areas in science love to disagree, like you hear the cardiologist disagreeing with the kidney specialist all the time. But I feel like one area where everybody can kind of find middle ground is that balance is the most important thing. It doesn't need to be like super all over the place. When we're dealing with pathophysiologies, that's when you're trying to bring things down or push things back up. But when we're talking about general health, it's just balance is like the most important part.
And I think when it comes to specialties, doctors should refer out when they don't understand. Like I took classes on cardiology. I'm not a cardiologist, so I don't speak to heart stuff, right? I would send someone to a cardiologist. Same with renal stuff. I'm very well versed in kidneys. I was born with a kidney disease, but that doesn't mean I'm a nephrologist. So I have a nephrologist and I refer people to a nephrologist for those issues. They spend 8 years in school focusing on just that organ, where I spent looking at, the endocrine system. So I think that's where some of the issues come from. It's like a cardiologist will speak about testosterone. Why are they doing that? So right. Refer to someone who knows what they're talking about that. If you're having a heart attack, I'm not the one to come and see.
And this is actually someone I know very well that works at U of M cardiology. Now, they're not a researcher, but they work in cardiology, and they were telling me that some of that initial estrogen being cardioprotective, how do I put it, thought, like what led them to starting to research that was just basically looking at trends between men and women and cardiovascular events. And they saw that there's a big gap between men and women. Therefore, thus women have more estrogen. Thus, estrogen must be cardioprotective. Thus, they have less cardiovascular events, so on and so on and so forth. And I think that's anecdotally, again, secondhand, not a researcher myself.
Not to say that it doesn't line up, right? When women go through menopause, then there's a different set of health problems when they're estrogen.
Right, and that was
doesn't mean that in men, it's going to be the same situation.
Yeah,
but then also there's like the dietary differences too. Right. Like a lot more men are going to be more like you almost never hear women saying, oh yeah, I'm going to eat more red meat. Like that's something you never hear, even though like red meat inherently isn't necessarily like going to kill you and like going to make your heart go poof. Eating too much of it is like a bad thing. Like too much anything is bad. Like I think I had a discussion with you about this last time, Justin, about like blood sugar and then cholesterol. I'm not sure if it was you or Mike, but it was like too much blood sugar is bad in the same way too much cholesterol is bad. But you never hear women saying, oh yeah, I'm going to eat that giant steak. You never hear that. So it's like, it's also, you're comparing two different groups of people with two different lifestyle factors, two different genders, two different like what is like metabolically and hormonally healthy, and then you're trying to conflate that. Like, this makes no sense.
Yeah, I mean, with all this stuff, like in my growth hormone book, it specifically says in the beginning that growth hormone is sexually dimorphic. The book is aimed at men, not women's growth hormone, because it's their bodies deal with growth hormone totally differently than men do, right? I mean, IGF is a totally different thing in a man's body than it is in a female's body.
Can you walk through that a little bit? That was one of the questions I had, was a two-part question. One is just kind of high level for the people listening in, like how is it different? A, and then B, I believe, again, I'm going off memory, I believe we discussed this, Kurt, where what markers are crap when it comes to determining IGF-1 and growth hormone versus what's actually, is there one that's helpful out there? I can
explain that. Like I can try to do it in simple terms. So
yeah.
Men and women obviously are different, right? Physically, from a genetic point of view, we're different. The growth hormone response and the way the body deals with growth hormone is different in men and women. And part of the reason is to limit a female's ability to grow muscle, right? Women are not designed from nature to be overly muscled. And IGF is the most anabolic hormone in the body. So when a woman's estrogen goes up, right? A women's estrogen is constantly moving throughout the month, but it tends to sit slightly higher than a man's estrogen, or at least above the range where a man should be. Estrogen renders IGF basically useless in the blood. So it binds, it creates, when estrogen goes up, the liver produces more binding proteins, it binds onto IGF and it creates it in serum. So bodybuilders get this wrong because they run a bulking cycle in the winter and they get really fat and their estrogen goes up and they go get their labs done and they're like, look, my IGF is a 600, I'm getting huge. Meanwhile, none of that IGF is actually entering a cell, or a cell that we care about. It's not entering muscle. Mm-hmm. It's interacting with all sorts of other things, but it's not necessarily going where we want it. And that's also what you see with the fetus. So it's also to protect the baby. A baby tends to grow from IGF-2 that's secreted from the placenta, which has a totally different effect on a fetus than it does on an adult. That's why we don't have any real level of IGF-2 in our body. It's not doing anything. But it's going to cause a different level of growth than you would see from IGF-1, right? You don't want a fetus to be exposed to IGF-1. And that's where those long-acting growth hormones came from. And that's why for months I was telling bodybuilders not to mess with that stuff, because it wasn't designed for what bodybuilders want. It was designed to mimic IGF-2. That's why it was steady and like this, which is what you see with IGF-2. You don't see big spikes in response to food. So women also have different peaks of growth hormone than men. It's just that their body's entirely different, the way it's going to handle growth hormone and what the IGF output is going to be in response to that. When you're looking at blood work, it's the IGF serum test was not created so a doctor could tell how muscular you'd be or what your potential for growth was from a muscular standpoint. It's used to determine a disease state, either a deficiency, like children that don't produce. Sometimes, rarely, you see children that produce growth hormone, but their liver doesn't produce IGF. In that case, they're given IGF, Increlux. That's rare. Or you see, which is very common, more so in men, you see pituitary adenemas, which is basically a non-cancerous growth on the pituitary. And if it presses in the right place, it causes a tremendous output of IGF. And you'll see that in their serum. They'll have a 2000 level of serum IGF. Those people don't present as particularly muscular. I don't ever see a guy walk in with that who looks like Arnold Schwarzenegger. They tend to, if they let it go long enough, they'll have misshapen bones and hands and feet and head. But that test is usually just used as a diagnosis for disease. It's not a reference for anything that we're looking for from a performance standpoint. It's good to test because it tells you what your pituitary is doing, it tells you what your liver is doing, but it's not a reflection on your physique. And when we look, so a lot of the things in serum, not testosterone per se, but what total testosterone fall in this, DHT, for instance, is when DHT is in serum, it's not really telling you anything because DHT and estradiol are created inside of a cell. When you test the serum, it's basically what was spit back out into the blood. So you're testing basically the waste. So with estrogen, we can at least get a relative reference as to what's going on inside the cell based on what's in the serum, because it seems to be a relatively equal amount. DHT, for instance, though, when it gets spit back out, it's bound to sex hormone binding globulin, and it binds much more firmly to sex hormone binding globulin, testosterone or estrogen, and it renders both the sex hormone binding globulin useless and the DHT useless. So testing serum DHT isn't showing you anything. it just shows you how much waste your cells basically spit out. Now, it might show that you 5-alpha reduce more than someone else, but it's not, you can't really solve anything with that. So it's kind of a useless test. It's not something I really recommend most people get. And estradiol can be funny too, because you can see a guy who has low estrogen, low sensitive estradiol on his blood work, but yet he's got estrogen side effects. And sure enough, inside the cell, there's a large amount of estrogen going on, but he's not a lot of it's not getting spit out. Or he has, like you and I talked about in a video a while ago, like he's got something going on with his digestion and he's not excreting the estrogen at an appropriate rate. So it's magnified, right? It's going back to the liver, right? Justin, you and I talked about this.
Yeah, we remember that.
So there's tons of issues, but yeah, serum, it would be like if you just judged everything total testosterone, non-sensitive estrogen, DHT, it's not actually telling you anything about what's going on with their health, and IGF.
Question as far as we don't really have a specific to check IGF-1 or growth hormone because there's no tissue specific reading for that. Am I correct? Like we don't have specific testings to see what's going on at I guess that would be like a genomic expression at the gene
you
level.
could do a biopsy, but it's not going to be covered by,
Sure.
it's not going to be covered by insurance, and I don't know where you'd go to get it done.
Yeah.
You go to a university.
Yeah, you would have to really good lab here.
Yeah, you could do a growth hormone serum test if you really cared. I would say if they're looking from a performance standpoint and they're injecting growth hormone, I would have to say from my own personal experience that growth hormone is fairly dramatic, and you would know if it was real and it was working. There's really no way to know that just because your hands went numb doesn't mean it's doing anything. I mean, anyone I don't know if you guys have used growth. I have a prescription for it. I'm on for my kidney issue. Growth hormone is very dramatic. Very strong. So there's really no mistaking if it's working. So if someone is using it and they're curious if it's real or not, most likely it's not real. Regardless of the dose. Even a low dose, it's strong.
Ella, were you going to comment on that from the research standpoint? Or?
I was just going to say, like, well, first, I feel like a lot of people hype up growth hormone a lot for like just in terms of everything because growth, and they assume like anything that increases growth hormone is going to make you super muscular. And if you have astronomically high growth hormone, you're going to be super muscular because it has the word growth in it, which I just think is it's a very social media sort of like the way that it's like propagated. Like you hear a lot of people peddling like the whole, like the hot showers or the cold baths or the stuff like that.
Or fasting.
Yeah, exactly. To increase growth hormone. And like at the end of the day, it's like people don't ask, what is this actually doing? Like, is it actually going to help me? Or is it just giving me like a temporary spike in growth hormone that's going to just come back down?
Yeah, just like exercise, right? If you squat, your growth hormone goes up. It doesn't mean anything. So the growth hormone itself doesn't interact with the muscle in this standpoint. So the growth hormone receptor on muscle is not allowing the growth hormone itself to enter the muscle. It's causing other gene transcription to occur. That growth hormone is a cytokine. So it actually, there's many reasons why you shouldn't inject growth hormone intramuscularly. The main reason is it degrades locally when it's put into a muscle because it's a cytokine. So if you force GH into a muscle, the body has an immune response to it because it senses that now it's being attacked by something. So it starts to degrade it. So you lose at least 20% when you put it in a muscle. So if you're using a generic growth hormone that's already only getting about 50% of it anyway because of the fillers, and then you stick it in your muscle, you're getting almost none of it. You might still get side effects, but that doesn't mean it's actually doing anything at that point. It's the IGF that people should be concerned with, which is the opposite of the GH, right? So if they're doing these things naturally, like shocking themselves or starving themselves or fasting to get a GH response, that's not going to cause an IGF release. IGF responds to protein, glucose, and calories, a fed state, not so much the opposite, right? Growth hormone is a hormone that comes out when there is a lack of food or stress. IGF is a hormone that comes out when there's abundance and it's time to grow. So growth hormone is called growth hormone because it causes bone growth, collagen growth, all those kind of things are just not muscle, unfortunately.
Which is the main thing they're looking for, right?
Yeah, well, why we use it clinically is not for the GH. Like right. If you read Genotropin's insert, Ceristim's insert, it specifically says that 80 to 85% of the effects from this drug are through IGF-1. It's just a much more efficient way to get IGF-1 than using Increlux. And it's more cost effective. Insurance doesn't want to cover that unless they need to.
I think, oh, sorry.
Go ahead. Go ahead.
I just wanted to say, I think another potential reason why like some of these drugs might not specifically act on muscle is because muscle grows in such an interesting way when it comes to like the way that we think like hypertrophy is, because it's like specific muscle fibers grow more than other muscle fibers due to being more oxidative or being more glycolytic versus oxidative. And then there's also like the literal way, which is hypertrophy, which is something we don't see in many cells aside from like fat cells. But like even that, we know that fat cells grow both like they're hyperplastic and hypertrophic. Like muscle is one of the very few cells in the body that is like predominantly hypertrophic in like a physiological way, which is kind of crazy to think about.
Yeah, well, it's only hyperplastic when generally in utero, right? Or
Yeah,
if you
when you're like
large
growing.
amounts of growth hormones, if you take large amounts of growth hormone, muscle will experience hyperplasia, but that's through IGF, right?
Mhm.
Because normally there's 4 pathways that muscles grow through. One through exercise. Mechanotransduction is the only way that muscles grow from exercise. Metabolic stress and those things have no effect on muscle growth. Then you have P13K, the androgen receptor, and the IGF-1 receptor. Those are the 3 chemical responses from drugs on muscle growth. Where was I going with this? When hyperplasia is going to occur, normally, right, you have a stem cell that commits itself to that pool for muscle, and then for hypertrophy, basically you donate a nuclei to that muscle cell, which makes it bigger. Hyperplasia basically donates the entire cell, but in order for that to happen, you have to have stimulus at the IGF receptor over a certain threshold to activate that, so it'll pull that cell in. Otherwise, it's not going to occur, and you'll just get a nuclei out of that, which is fine for what most people are looking for. Most people just want to be more muscular. They don't necessarily need hyperplasia. If your goal is to be a 300-pound bodybuilder, most likely you need hyperplasia to occur. Otherwise, you wouldn't be. That's what you really see the difference in modern bodybuilding with versus guys like Arnold Schwarzenegger. That's really the difference, is that there's no hyperplasia that's occurring from all sorts of drugs that are allowing that to occur. That was never the case, when they would use Deca and Primo 50 years ago.
I'm curious for P13K. I know that that's a part of the whole insulin pathway as well.
Mhm.
That's also going to be potential. That's like that pathway is what you're talking about.
Yeah, so IGF will actually hit that as well. So that's
Yeah.
a highly conserved energy sensor, right? It's part of mTOR, and it's normally used for food, but it's when your IGF levels are high, it basically activates that receptor and tells your body that there's energy excess, even when there's not. And that's why you see growth. Like if you went to Africa and you found children who are very malnourished, they generally still reach adult height. It's because of that path. Like when you're growing, adrenarche and later in puberty, when things like IGF are very elevated in that anabolic environment, you'll get growth through that pathway, even if there's no adequate food. As an adult, again, unless you're doing huge amounts of GH or taking IGF, you're not going to activate that pathway in a sufficient way to allow growth to occur without eating, right? So it's why a natural athlete needs to be in more of an excess. A bodybuilder that's on a bunch of drugs, right? If you take trenananadrol and test and GH, you can grow in a deficit. Whereas, you're not going to do that if you're a natural person. You have to, right? Your food has to be in excess. We've all experienced that before, right? If you want to put on weight as natural, what do you have to do? You have to eat more, right? And you get fat, and you have to diet that fat off. That's the difference, because you're only relying on that mechanotransduction pathway to grow.
I am kind of curious because I've noticed that it's not entirely just eating more to put on fat, because I've noticed the extra fat has not necessarily benefited in the same way that it's a very slow process for naturals. So eating, even if it's not as much of an excess to the point where you're putting on so much excess fat, because if you're getting to that point, then wouldn't that be partially
Like detrimental to the process?
yeah, detrimental. Yeah.
Well, that's, and people don't like this fact. So the energy requirement for muscle growth is not as great as people think, whether you're natural or not, right? When do you actually need, you might know this better than me, this might be more of your thing. The energy requirement is during protein translation, I believe, right? And it's just looking basically for that sensor to be activated to show that you've eaten. And it basically, carbohydrates are going to do that. But what is the actual energy requirement? 200 calories at the most. It's very minimal. And honestly, a lot of these things are misdefined. Technically, you could grow at maintenance, because people don't understand what maintenance means. Maintenance, people assume, means you're sitting on a couch. Well, if you're somebody who's active like all of us, maintenance includes working out. That's part of to maintain your body. So technically you could grow up maintenance because that's affording you the extra energy to work out, right? The excess, yes, excess calories isn't going to contribute to muscle growth. You can't force feed muscle growth. It's not like there's some channel there that just, is just shoveling energy into muscle and it's growing. I think people experience, guys like the scale, probably women, some if they want to get more muscular, some like the scale in the opposite way, but they're looking at food because then they eat, they get bigger, right? Their shirt fits tighter, they get stronger. They're looking at all these metrics that don't actually anything to do with muscle growth per se. And they just assume that the more they eat, the bigger they get. And that's unfortunately not the case, right? Mechanical transduction, again, has nothing to do with food. It's an electrical signal. When mechanical tension is experienced, it is nothing, like the body's not looking for food there. It would grow plenty fine at maintenance.
I was also kind of curious when you say the P13 kinase, does P13 also kick MAPK and like the whole MAPK cascade as well?
Mm-hmm.
Oh, that's very interesting. Yeah, I'm going through all the learning stuff, so it's
I don't learn it specifically from an exercise point of view. I talk to people who are exercise physiologists. We look at it from a disease point of view. Like, how do we deal with something like an HIV or a cancer, if someone's bedridden or something? And that's how these drugs are designed and how you manage these things is basic. And that's why anabolic steroids are traditionally used, or growth hormone is used to prevent wasting and things like that in those horrible situations, because they'll hit other pathways where if someone can't eat or if they can't lift.
Yeah, I was, that's actually the area of research that I'm planning on going into as I go into grad school. I've been vetting out this one laboratory doing all research in muscle physiology and cancer-associated cachexia, because that's like the area that I really want to go into. So I'm sure I'll run into some of it. It is something really interesting that I'm sure you could probably appreciate as somebody who's in endocrinology. There is this one review paper that is a really big review paper in that lab that was discussing some signaling mediators of cancer cachexia. And it found that some of the potential ones that were being found through preliminary studies in mice were not crossing over into humans at all. There was this one myostatin therapy for a phase 2 trial that actually had really bad effects in the patient population, but had a really anabolic effect in mice, which I thought was really interesting. So I'm sure
the genes are totally different. Even the way we metabolize drugs are different, right? Unfortunately, with the original steroid stuff, a lot of them are done on animals, and the data doesn't really cross over to people. So with trenbolone specifically, we metabolize trenbolone much more similar to a cow than a rat does. They actually have totally different metabolites from that drug than we produce. We know there's 77 genes in anabolic steroids or growth hormone interact with inside a muscle that can cause muscle growth, and each drug will interact with them in a different way or in a different order. Nandrolone is completely different from trenbolone, which is different from testosterone, which is different from Anavar. And that's stuff that you would dive into if that's the area that you get into, which is kind of cool because it does cross back over into exercise to some degree, because there is crossover with those genes. But yeah, there's all sorts of stuff that you see in mice that is not relevant to people, myostatin included. We're not really sure what myostatin is actually, it's pretty irrelevant, I would say, in the whole scheme of things.
That's really interesting too, with what you're saying about the food, because it was just more of a curiosity. You would hear studies in HIV patients using Anadrol or some other form of a growth agent that traditionally you hear anecdotally out there that it downregulates their ability to eat, or their hunger signaling, or whatever the case may be. So then when you mention that the other pathways will help combat by using those drugs the muscle wasting, that makes a lot more sense. Because it was always a curiosity. I'm like, well, they're using it for muscle wasting, but you hear that people can't really eat while they're how does that work?
Well, it's specifically in something like HIV, you have other genes that are being expressed that we don't express, like forkhead box, severe wasting genes that we don't express at all. And they're also losing cell mass. So if you're bedridden, you'll lose cell size. Your muscles will atrophy, but you're not actually losing those cells. Whereas in HIV, the cell mass goes away. And that's where growth hormone therapy came in, because they realized that there was really not any amount of steroids that they could give someone in a safe manner that would allow to do cell mass, versus growth hormone actually increases cell mass. But the dose, again, has to be high. And I think this is where, again, we don't know what the amount is when it's mixed with steroids. That's something that I hope to explore. After I'm done with this testosterone thing, it's actually the avenue that I want to go is I want to actually figure out what amount of growth hormone actually causes hyperplasia in the presence of certain androgens, because we don't know that. We only know like monopharmacy with these drugs. So we know with growth hormone, it takes 6 milligrams a day. If you want an AIDS patient to, assuming they're over 140 pounds, if they need to gain cell mass that's permanent, it takes 6 milligrams a day, which is a bottle of Serostim a day. When we've used other amounts, even if the cell mass seems to increase, as soon as there's a washout period, the muscle goes away. Whereas the 6 milligram mark basically allows permanent new tissue to be formed that does not go as long as they stay on antiviral medicine. So that's kind of where these dosing things came from. And then if you look at things like growth hormone for HRT purposes, the dosing all there was made up. So doctors will argue with me, no, 1.7 units is the effective amount, which they've just literally pulled out of their ass because there's no data to show that that does anything. That's not necessarily going to, outside of maybe some long-term cosmetic effects. I'm not really sure what it's doing because there's no data there at all. Or we only know in disease states what it's doing. And that's why the dosing is always super high. And I'm not saying doctors for HRT should be writing 18 units of growth hormone, but there's unfortunately no FDA approved use for HRT. So we just don't know. They're literally making that stuff up. So guys will argue with me on the internet all the time. Like, I use 3 units and it's phenomenal. I'm growing. Like, there's no way you're growing from that because it doesn't work. If it worked, you think the FDA or you think insurance companies would want to pay for bottles of Serostim a day for people with HIV if they could get by with 3 units? They'd much rather give lesser amount.
The saturation model and limits of androgen-dependent growth. Is that something you're familiar with? I know there's a study in 2009 where they were talking about the saturation model. I can read like an excerpt from your opinion.
What?
So it says, blah, blah, blah. According to this concept, prostate cells. So I should frame this up a little better. It's regarding prostate cancer. So according to this model, it's talking relative to TRT. So we get questions from clients, patients, for our physicians saying risk for prostate health relative to TRT. So it says, according to this model, prostate cells reach a saturation point at a relatively low testosterone level, around 250 nanograms per deciliter. This means once testosterone reaches this threshold, additional testosterone has minimum impact on prostate cell growth. As a result, men receiving TRT typically aiming for testosterone, and it gives a lower range than probably what they should be given, but even as high as 800 nanograms per deciliter are not likely to increase their prostate cancer risk relative to that because of that saturation theory.
In every cell, but it's not that low in most cells. The prostate's different. So I'm not an oncologist, but I'll give a brief summary of how those things work. So the hormone-dependent cancers, you have basically, in that case, estradiol would be the carcinogen. And then that will allow that to start. And then it's also a lack of vitamin D and a lack of thyroid hormone. So that's a perfect storm, which you see, right? In tons of Americans, they have no vitamin D.
Yep.
They probably have no magnesium either. So even if they have D, they're not able to use it. They have poor thyroid function from being overweight or poor diet, poor lifestyle choices. And then they aromatize, right, because they're heavy. So then a lot of the testosterone is becoming estrogen. So then the cancer starts to grow. What allows it to then further grow is it generally needs an androgen and an IGF-1. So then those two things allow the growth to occur, right? So they're not carcinogens. IGF is not a carcinogen. It can't cause cancer, but it will allow cancer cells to grow. Right. Certain cancers actually secrete IGF to further their own growth. And that's another reason for the serum IGF test is sometimes you'll see in cancer patients their IGF will go really high because certain tumors will secrete. We're using TRT more and more in prostate cancer. And even in later stages, it shows that it actually doesn't affect it at all. Like if someone is, stage 3 or stage 4 prostate cancer, keeping them on TRT is not going to be detrimental at that point because the prostate's already doing its thing. There's no reason to deprive them of testosterone. The original deprivation therapy was kind of misunderstood. Yeah, they were removing the androgen and the IGF, but they were removing the estrogen was the thing. There was just no aromatization occurring, so the cancer would stop growing, which you destroy someone's life by pulling out. If you take a man, you fully block, use flutamide or something that's going to fully block androgens. What is the quality of your life at that point, right? And then on top of it, if you remove the prostate, that's fantastic that you're now cancer free, but you have zero, going on down there. So.
Just to briefly touch on the vitamin D thing, because I just thought it was kind of interesting. I did a little bit of looking into it a while ago, was that vitamin D actually plays a role in certain checkpoints during the cell division cycle, which likely plays a role in protecting the DNA, especially if there's any mistakes, because the enzymes that are responsible for replicating DNA kind of suck. So they make so many mistakes, and it's probably very significant that if you are deficient in vitamin D, that you're not able to, your cells are not able to proliferate properly, so they end up getting a lot more mutations.
You'll see the prostate actually start to swell too as the vitamin D levels go down.
Mm.
It's basically like the vitamin D receptors are expanding to try to get more vitamin D, and there's no vitamin D present. And if you look at, unfortunately, if you look at the demographic where prostate cancer tends to be the worst, it's in the darker someone's skin is, the more likely they're to get prostate cancer, and that's related to vitamin D again, right? Because even if they're in the sun, they're not absorbing the same amount as someone with fair skin.
It makes a lot of sense. I was just dabbling around in an article earlier today where it was the relationship between testosterone, vitamin D, and prostate cancer. So it was kind of talking about how all those three interplay. So that's really interesting.
You know, I'm always hesitant to speak. Cancer is one of those things that's like, especially because that's not my field. I'm always hesitant to speak to it because I don't want to make a mistake or make any claim that there's some sort of cure or something.
Right, of course.
If we knew exactly what caused it, there would be a cure.
Sure.
As you know, there's a million pathways that are occurring that we just don't fully understand what they occur. And DHT would not have any role, like negative role in that either. It would actually block, you know, the estrogen at the receptor there too. That's another place where they went wrong, right? That's why women for cancer years ago, they used DHT derived drugs in inoperable breast cancer. The problem is it virilized them, so they just stopped using that stuff. But drugs like Masteron and Primobolan were basically invented for that purpose, to stop estrogen expression.
Interesting.
And that'll cause, DHT can cause benign hyperplasia of the prostate. So it can cause it to swell, where if you do a steroid, it's not a permanent like cellular change or anything. Right? DHT can't be a carcinogen because it's structured as a saturated A ring. So carcinogens don't have a saturated A ring. Like estrogen does not have a saturated A ring.
That's very interesting. And I see, just from like what I remember from organic chemistry, I can see why estrogen would be a carcinogen. But I find cancer biology really interesting, which is the only reason why I read a little bit about it. But I'm by no means an oncologist, and I don't plan on going down that route. I just like to do research.
Appreciate discussion, even if it's scratching the surface, just to give people a little direction when they're kind of going on that rabbit hole, when they're talking to their physician, a little more knowledge, a little more context to maybe their questions and how to frame those up. But appreciate you guys coming on, sharing some content. And with that, we'll see you. Have a good one. Transition.